This section will cover primary hemostasis disorders, particularly disorders of platelets, as well as acquired disorders focusing on DIC in relationship to coagulation disorders. Remember that primary hemostasis is the formation of the platelet plug. Without platelets, primary hemostasis cannot occur. This leads to bleeding that can be seen as, in addition to other things, pinpoint small little dots of blood on the skin surface that is called petechiae. You can see that in the picture here. These dots do not blanch. Remember that normal platelet count is 150 to 300,000, and less than 100,000 is considered to be low platelets. Thrombocytopenia is when the platelets are less than 100,000, and this increases the risk for bleeding. As the platelet drops, the bleeding increases. Intracranial bleeding would be one of the most dangerous complications of thrombocytopenia. Causes would incur anything that causes decreased production of platelets, like bone marrow suppression. In this case, megakaryocyte numbers would be compromised. Aplastic anemia causes decreased stem cell in the bone marrow. Leukemias cause immature white blood cells to crowd out the bone marrow cells, and radiation decreases bone marrow activity. Lack of folate and vitamin B12, as seen in megablastic anemias and pernicious anemias, decrease the erythropoiesis that is that vitamin B12 assists with, and red blood cell maturation. Drugs and such as bone marrow suppression from chemotherapy or sulfa drugs, or antibodies that form and attack platelets from things like antibiotics and thiazides can decrease platelet formation. Alcohol itself decreases platelet formation from poor diet and liver disease. And in particular, hypersensitivity reactions in which autoantibodies destroy platelets are extremely problematic, especially with type 2 reactions. And in hypersplenism, remember the platelets, at least 90% of platelets can pool in the spleen, which of course would lead to thrombocytopenia in the blood. Heparin-induced thrombocytopenia, or HIT, occurs in 4% of patients with who are receiving heparin. This is a drug reaction that is immune-mediated by IgG. The IgG binds with receptors on the platelet, causing aggregation with release of granules and activation of the clotting cascade in both the arterial and venous systems. This is a type 2 hypersensitivity reaction. Platelets decrease 5 to 10 days after starting heparin. The treatment is to stop the heparin and possibly to use argatroban to inhibit thrombin formation. Of course, you want to avoid anything that's going to increase the risk for further bleeding, such as low molecular weight heparins or warfarin. Acute idiopathic thrombocytopenia purpura, or ITP, is a disorder of platelet consumption in which antiplatelet antibodies bind to plasma membranes of the platelets, causing destruction of the platelets by mononuclear phagocytes in the spleen. The destruction of the platelets exceeds the ability of the bone marrow to produce new platelets. Usually this follows a viral illness such as Epstein-Barr virus or cytomegalovirus, or any respiratory viral infection. In this case, IgG initiates the immune destruction, so this is also a type 2 hypersensitivity reaction, and is most prevalent in females between the ages of 20 and 40. Clinical signs of ITP are a generalized rash and purpura 1 to 4 weeks after the infection, and hemorrhaging of the mucous membranes. The condition lasts about 1 to 2 months, and there is a good chance of recovery unless there's brain lesions where bleeding in the brain can be fatal. Corticosteroid or prednisone therapy reduces the severity and shortens the duration of ITP by suppressing the immune attack on the platelets. A splenectomy is reserved for chronic cases only, and other measures that don't respond to the typical treatments. Immunosuppressive therapy is used as a last resort. There is a chronic form of ITP seen more in adult women between 20 and 40 years old. It's important to protect these patients from trauma because that, of course, without the platelets would lead to more bleeding. Disseminated intravascular coagulation is an acquired disorder. DIC is an acquired disorder, which means that it comes from something outside of itself or ourselves. In DIC, there is a consumption of platelets, fibrin, and coagulation factors, with secondary activation of the fibrinolytic system. So what we see is a patient who is both bleeding and clotting at the same time. As you can see from this diagram, which is in your textbook on page 276, DIC can be activated by either the intrinsic or extrinsic pathways by a number of different causes, which we'll go over in a little while. But what happens in either case, thrombin is generated. As thrombin is generated, we get intravascular fibrin deposition causing thrombus or clots. We also get platelet consumption as the number of clotting mechanisms increase, and then we get thrombocytopenia, which, as we've just seen, leads to bleeding. There's also activation of plasminogen because we need to decrease the clotting that we're forming, so we have increased fibrinolysis causing bleeding at the same time. So what happens is that because there's all this clotting going on, mostly in the microvasculature, is that the clotting factors get used up. So now we have this fibrinolysis system occurring, which is causing bleeding throughout the body. This diagram goes into much more detail regarding the consequences or complications of DIC. You can see that it can start by a direct tissue injury or cytokines, endotoxins, causing both an endothelia-activated injury and a mechanical tissue damage, and all the consequences that lead down to the bottom of this slide, which leads to blood loss, which would cause hypovolemia, decreased cardiac output, tissue hypoxia because of lack of blood flow, ischemia, infarction, necrosis, and finally MODS, which is multi-organ dysfunction syndrome. The next 3 slides will sort of review or summarize the pathophysiology of DIC. First, because there's endothelial damage with exposure of collagen, this activates the Hageman factor in the intrinsic pathway. Also activated is tissue factor, which is released from the extrinsic pathway. Due to activation of the intrinsic and extrinsic pathways, there is widespread depositing of fibrin in the microcirculation, forming clots. The natural occurring anticoagulants, antithrombin 3, protein C and S, are suppressed, thus allowing for more widespread clotting to occur. Ischemia occurs in the organs due to blood flow disruption, leading to infarction, necrosis, and organ failure. This can affect all areas of the body system, the renal system, the cardiovascular system, the pulmonary, the central nervous system, the hepatic systems. Unfortunately, it's very difficult to detect damage to these organs until it has resulted. Hemolytic anemia develops because the RBCs become fragmented as they try to squeeze through the narrow vasculature. Because of this increased deposition of fibrin in the microcirculation, the clotting factors and platelets are used up, and this then leads to a depletion of clotting factors. At the same time, fibrinolysis is occurring, so we have the fibrinolytic system changing plasminogen activator to plasmin, causing hemorrhaging problems as well. Fibrin degradation problems are increased, and this contributes to further bleeding because FDPs inhibit platelet aggregation and also has antithrombin activity, so this further complicates the issues of the bleeding in DIC. So you can see from the activation of both the intrinsic and extrinsic pathways, we have increased clotting. This increased clotting depletes the platelets and clotting factors and also activates the fibrinolytic system, which leads to hemorrhaging, which increases the FDPs, as I already said, which act as anticoagulants, causing further bleeding and thrombocytopenia. There are many causes of DIC, as can be seen in this slide and the next, as well as in a list in your textbook on page 276. One of the major causes of DIC is sepsis from gram-negative bacteria. This sepsis causes a systemic inflammatory response, or SIRS. So 2/3 of people with SIRS develop DIC. The sepsis causes vascular endothelial damage, releases endotoxins and cytokines, and proteases, which are all associated with inflammation and cause damage to the tissues, leading to DIC. Remember that in systemic inflammatory response, that the patient has extreme extravasation or third spacing of fluid. This leads to hypotension, this arterial hypotension is associated with activation of kallikrein and complement system. Remember that kallikrein also releases kinins, and kinins further increase the permeability of the vessels and lead to further third spacing and hypotension. So this worsens the shock associated with the SIRS as well as with the DIC and the blood loss associated with it. The classical sign of DIC is blood oozing from everywhere, from the tear ducts, from the nose, in the urine, from the pores, in the stool, from any orifice, some that the patients have, and those orifices that we make. We start an IV line, and blood oozes from that site as well. So we see bruising and petechiae as well. Anytime there is at least 3 unrelated sites where there's bleeding, we should highly suspect DIC. Because there is excessive bleeding everywhere, the patient is at high risk for hypovolemic shock. They are also at risk for intracranial bleeding. If they have start having bleeding in the head, then you do see part of the most classic sign would be a decrease or a change in level of consciousness, headaches, and pupillary reactions. But first and most classic is a change in level of consciousness. We also see GI bleeding, including internal bleeding in the stomach, abdomen, and gut, which leads to further hypovolemia. The skin will be pale and mottled or cyanotic. They may have jaundice because of red blood cell destruction and liver failure. In addition to the complications from bleeding, there are complications from thrombosis that occurs. There's microvascular thrombosis, which if occurs in the brain can cause change in level of consciousness, confusion, seizures. Microvascular thrombosis in the heart can cause chest pain. In the extremities can actually cause necrosis and gangrene of the digits. Thrombosis in the lungs would be pulmonary embolism, and the patient you'll see would be chest pain and tachypneic. They might have pink frothy sputum and hypoxia, apprehension, and hypotension. It's very important in DIC that we look for clotting in any organ area, looking for end organ dysfunction, renal failure, liver failure, gut failure, myocardial infarctions, etc. As you can see, there are many labs that can be drawn, and many of them are associated with the DIC. Of importance is the D-dimer, which is a gold standard because it indicates both fibrinolytic and clotting systems have been activated. So we may have a prolonged bleeding time, a decreased platelet count, increased fibrinogen and fibrinogen degradation products. PTT may be prolonged, and of course we would have a decrease in clotting factors. What you have to think about when you're thinking about the lab values is that there's going to both be procoagulant activation and fibrinolytic activation. So you're going to see both the values from both of those systems showing that we're having coagulation and we're having lysis of clots. So it becomes very confusing to look at. It's very important that we're looking for end organ damage or failure. So in addition to what we've talked about as well, you'd want to look at BUN and creatinine and cardiac enzymes and liver enzymes and other organ lab values. The key to treating DIC is to find the underlying cause and treat that. If the underlying cause cannot be determined, then the patient will not survive. In the meantime, as we're looking for the cause, we need to support the patient hemodynamically. So we need to provide volume and oxygen, prevent acidosis. Once the stimulus is identified and removed, the liver can usually restore normal levels of clotting factors within 24 to 48 hours, which would control the bleeding that's been going on. In DIC, each patient is treated individually and depending upon the clinical picture. We might choose to give a potent anticoagulant, such as heparin or anti-prothrombin 3. These agents may be used if blocking coagulation is paramount. For example, if there's a risk of losing an extremity due to an occlusion or organ failure or organ function is compromised. Remember that heparin prevents further clots from forming and does not alter the clots already formed. It stops further thrombus formation. We might need to give platelets or cryoprecipitate if the problem is the bleeding that's occurring. In either case, the patient will probably show signs of shocks. We need to control the shock by giving fluids and vasoactive agents that will help improve the blood pressure, provide oxygen so that tissues can become oxygenated, so that each individual patient is treated depending upon the symptoms that are most affecting them at that time, and may change back and forth between different types of therapies. Finally, providing good patient care to the patient in DIC is imperative. As nurses, we know to reposition every 2 hours and to do good skin care to protect the patient from injury in order to risk further bleeding. And once the cause, as I said before, once the cause is determined, then all we're doing is supporting the patient until the cause can be eliminated and the liver can reproduce clotting factors. Patients do survive DIC, but it's a long, arduous, highly intensive situation that requires very close nursing monitoring. And this concludes the coagulation disorder section.